So I'd like to introduce our speaker today, talking about colposcopy. It's Miss Charlene Brogan, the lady in red, who's after running a very busy colposcopy session this morning. So thank you so much on your lunchtime giving us a presentation. She's also a candidate AMP in Women's Health and Ambulatory, Gynae and Colposcopy. Our panelist today, which you'll meet at the end of the presentation, is Louise McKee, our Senior Training Coordinator with the Screening Training Unit, and Dr. John Price. He is the colposcopy clinical advisor with Cervical Check. So over to you, Charlene.
Thank you. So today I'm going to just take you through an overview of colposcopy care, what to tell women being referred and receiving care. And hopefully at the end of the session, if I've done my job properly, you'll understand the principles of colposcopy and the importance of the appropriate referral pathways. You'll be aware of what to tell women attending colposcopy, be familiar of the treatments that we offer within the unit, and be informed on the advice given to women after treatments and possible complications that could develop. So referral to colposcopy, there are two pathways of referral. The first is with an abnormal cervical screening test or with persistent high-risk HPV. So this is when the woman has been invited to attend the surgery for her cervical screening test, and the result has come back that she's either persistent high-risk HPV or she's HPV with an abnormality noted. The other referral pathway is one that is less used. It is on suspicion, and it's strong suspicion of cervical cancer on inspection of the cervix. So you've gone to take a cervical screening test, looked at the cervix and think it is a cancer. So this needs to be with a phone call to colposcopy, and then the follow-up referral comes with it after. And referrals for reassurance shouldn't be made to colposcopy clinic. When you are sending a woman to colposcopy, it's the revision 11 and it's the pre-filled revision 11 colposcopy form that we require. And this is the one that comes to the GP surgery a few days after the electronic result. There's only a few things that need to be filled in this, and they need to be filled in legibly and accurately. That's consent for text reminder. Is English her first language? We're getting a lot of women, especially from Ukraine, coming through, and we need to have an interpreter to hand so that we're not wasting her time and an appointment slot. Is there special needs assistance required? Again, so that we can have it ready. Fill in the GP details section and sign it. Let us know if she's immunocompromised, if she's pregnant, you know, whatever we need to know to do the colposcopy examination. Does she have any allergies? And include her phone number, because we'll often do telephone triages. Finally, when that's all completed, you must attach the full test result. And this isn't the summary report. It's the one that has the lab name, the specimen number, the date of the test, and the full test result. So the HPV status and her cytology abnormality if it's present. If you don't have this, please ring the vendor of your IT system and they will provide you support to be able to get the full test report. So these are samples of the revision 11 pre-filled. You can see at the top here, Cervical Check will recommend what unit to send you to. This one is Letterkenny, and the details are all pre-filled. There's only a few sections that need to be filled in. And this is a sample of the full test report. You can see that the EC number is here, the date of test. This is page 1 of 2. So 1 is telling you that she's HPV positive. Page 2 will be saying ASCH if it correlates to the pre-filled revision 11 form. So please don't refer to more than one colposcopy units. It just causes unnecessary waiting lists for women. As I've already said, the cervical check will pre-fill which unit to send the woman to, and this is to ensure that if there's lengthy times in one area, they'll recommend somewhere very close by, and this will ensure that all women are seen within our standard waiting times. Now, women can choose to attend a different colposcopy service, but she needs to be aware, and you need to let her know that any deviation from the recommended unit may result in a longer waiting time for her. But if she's happy to do that, this is the form that you then fill out, and this is the one that's downloadable on Cervical Check website, and it allows you to tick whatever one that she wants to attend. So there's 15 colposcopy services within the country, and women can attend whatever one that they want. Now, waiting times depend on her result, so her sample category. If you have a look at the cervix and there's a strong suspicion of cervical cancer, you've picked up the phone, you've let us know. This is a 2-week wait pathway, and we will try to get this woman in as quickly as we possibly can. If she has a high-grade abnormality, and this will include high-grade severe dyskaryosis and moderate dyskaryosis or dysplasia, ASCH, and high-grade or glandular abnormalities will be a 4-week wait pathway. She will be seen, or we will try our hardest to see her within 8 weeks if she's low-grade abnormality, ascus, or persistent high-risk HPV. The woman will receive a letter from Cervical Check, and this will advise her to contact the nurse or doctor that took the test to discuss the abnormality that was found. Now, if this is well explained, we find that if she comes in knowing what the abnormality is and what it means and what's going to happen in colposcopy, she's a lot less anxious. So spending a bit of time with a woman at this consultation is really beneficial. And this is a free consultation for the woman. She will receive information leaflets. She'll receive the patient information leaflet, and she'll also receive the colposcopy information leaflet. Now, this is a really handy little document or tool to have to hand if she is asking you questions. It'll go through what a colposcopy exam is, why she might need it, who should she bring with her, or more importantly, who should she leave at home, like to try and get childcare, how to prepare for it, and to attend if she's pregnant, and it'll go through some risk factors as well. You can also tell her that it'll be in a hospital outpatient department. The examination will take around 15 to 20 minutes. She will go home on the same day. Please advise her to eat and drink prior to the appointment so she doesn't collapse on us on the way to the couch. Tell her that colposcopy can be performed at any time of the menstrual cycle except during heavy menstrual bleeding, and we'll reschedule for her if the appointment time or date doesn't suit. This is a video of ORT, and it's very short, of our colposcopy unit, just so that you can see. She comes through the door here. This is our waiting area. She'll have her details checked by the girls, the admin support, and we'll bring her through to colposcopy room 1. We have 2 of these rooms in Letterkenny. We'll do a consultation sitting at the computer first of all, and explain everything to her. When she's happy, then we'll move over to this area, to the couch, have her get undressed from the waist down. We have a curtain there. You can see the colposcopes there, the colposcopy couch, and our equipment that we need. And that's very, very briefly. Now, so when we do bring her in, we'll bring her into the consultation part of the room. We'll have her sit down. We'll discuss her reason for referral. We'll discuss the limitations of cervical screening. We'll answer all of her questions. We'll gain informed consent as well at this stage. And we'll discuss the colposcopy process. So what is colposcopy? It is a medical diagnostic procedure that investigates individuals who have abnormal cervical screening tests or persistent high-risk HPV infection. And this is to decide ultimately, is a treatment required? It's carried out by trained professionals. We are accredited with the BSCCP and need to re-accredit every 3 years. We carry out the procedure using a colposcope. You can see the colposcope is here. And it provides a magnified image of the cervix as well as the vagina and the vulva. We apply acetic acid 3 to 5%. So we use the 5% in Letterkenny, apply it to the cervix, and it causes a reversible coagulation of the cellular proteins. If I take it to this slide, this is a normal cervical cells. You can see the small nucleus to the large cytoplasm ratio. And it's inside the nucleus is the powerhouse. So it's inside here that holds the protein. If you come over here, this is an abnormal cervical screening test, and you can see that the ratio has changed, that the nucleus is much larger. It has, so obviously the larger the nucleus, the more protein content, and it's this that coagulates or kind of clumps, and we can see it then when we shine the light through, it shines as a white. And it's a landmark of where we can take the biopsy, and it'll tell us, is it, a high grade or is it a low grade? So it appears as an acetowhitening when inspected then by the colposcope. We can also use a Lugol's iodine, and it's another tool to help us see if there's an abnormality there. It'll shine back as like a saffron mustard yellow in abnormal cervical cells. And this is because it contains little to no glycogen. So when we get her up in the bed, we have to see the cervix. It's the most important part. If we don't see the cervix in its entirety, it's an inadequate colposcopy examination. So we have a few tools and tricks up our sleeve to get the cervix into view. Most importantly, we have the colposcopy couch. I'm not sure how people take smears out in practice. I don't think I could do it without my couch at this stage. It'll allow us to move the legs up to the sky, and she'll be doing all sorts of yoga poses that we can get a visual on the cervix. We also use a wide range of speculum. So we'll start with the very small, especially in the nulliparous women or wee small postmenopausal women. I'll try and start with the small speculum, and then I'll move my way up if I need to. And at that stage, you've gained her trust, so she's more relaxed with the small speculum going in, that she'll allow you then to keep going with the larger speculums to see the cervix. This is our colposcopy room again, and you can see that this is a picture I printed from the internet. None of the girls would get up in the bed for this photo for me, so I had to just start printing from the internet. But you can see this is the image that we can see. It's really, really good quality, and the woman can look at this as well. And there's another screen behind the woman that you can have a look. This is the colposcope, and the light shines. So everything that we see, the woman can see. We can reassure to say, look, everything looks healthy, or to say, actually, there's a little area here, and this is where we'd like to take a biopsy. When we are looking at the cervix, there's a few things we need to see. We need to find the squamocolumnar junction. So this is basically the area where the red meets the pink, where the columnar epithelium meets the squamous epithelium. And this is the new squamocolumnar junction. The old squamocolumnar junction is on out beyond it, and we're looking for the area in between that. So you can see here, so there's three types. It's the area in between the new and the old squamocolumnar junction is your transformation zone. And this is what we're looking for when we do a colposcopy examination. This is where the dysplastic cells can happen, or this is where the change can occur. So there's three types. There's type 1, which is my favorite, because you open the speculum, the cervix is there, and you can see everything in its entirety. You can see that everything's normal, and you can reassure the woman. Type 2, not so bad either. You can see it here, where you could manipulate the cervix and pull it down a little, and you'd be able to see the squamocolumnar junction in its entirety. So type 3 is obviously my least favorite. It's even with an endocervical speculum or whatever tools you have in your drawer, you're not going to see the squamocolumnar junction in its entirety. The normal colposcopy findings. So if we do have a woman up, we've applied the acetic acid, everything we can see is there, and there's no abnormal cells found. There's a few follow-up care options. We can discharge her or tell her that we're going to continue with her cervical screening test in primary care after 3 years. So this is irrespective of age. Although we have extended the period between 3 and 5 years for women over 30, because she's been to colposcopy, she will have a HPV test taken in 3 years. We can request that this is in 1 year, or we can decide, you know what, especially in the type 3 TSZs, we'll follow this lady up in colposcopy in a year's time, or whatever we choose. So the normal cervix, there is a few variants of the normal cervix, and we'll go through them now. The first is your normal eversion, or ectropion, or ectopy, whatever it is called. It is regarded as a normal variant found in women of reproductive age. So it's to do with being under the influence of estrogen, of hormones. It causes the glandular cells, which are usually up inside the cervix and the endocervix, to just become exposed on the ectocervix. So when you open the speculum, you can see it there. Now, this is a normal variant, and it does not require a colposcopy referral. And this will go through a process called metaplasia, where it'll change back to squamous metaplastic cells. So it'll basically turn back to pink. Another normal variant are Nabothian cysts, and these are small, basically they're like spots that you get in your face that are on your cervix. And it happens a lot when a woman has an ectropion. When metaplasia occurs, they get trapped in under, and they're normal. They're fine to be there. They're just light yellow or amber mucus filled cysts. Cervical polyp, again, no reason to be referring to colposcopy. They're small growths in the cervix, painless and usually harmless. They can cause some irregular vaginal bleeding, and most are benign. Then for an abnormal colposcopy finding, when we have a woman up on the bed, if we do see abnormal cells, we'll often take multiple biopsies to assess what's the risk of these becoming cancerous and is a treatment required. So the biopsies are very small. Women tolerate them really well. We don't use local anaesthetic in Letterkenny, but I do know that a few colposcopy units have reported less vasovagal episodes when they've started using them. So it may be something that we could audit, but the majority of women tolerate it really well. The types of abnormal results. So if we take the biopsy, we see the abnormality or the white area, we take the biopsy, we send it to the lab. It can come back then stating an abnormality, and it'll come back stating that it may have cervical intraepithelial neoplasia, so CIN. So it may be CIN1, CIN2, or CIN3. It could come back reporting a glandular abnormality, or it could come back with a cervical cancer being picked up, either an adenocarcinoma or a squamous cell carcinoma. So this is an image of a cervix. You can see that there is a CIN1. There's a low-grade abnormality on it. This is the acetowhiten. You can see that it's quite nebulous in color. The margins aren't distinct. It's in all 4 quadrants of the cervix. We could take biopsies of this and it'll come back a CIN1. Now, the majority of CIN1s will regress without treatment. Given time, the HPV virus will clear and it'll clear the abnormality. So the majority of these women will be returned to primary care for a cervical screening test in 1 year. Now, some patients will remain under or supervision until they regress or progress and require treatment, but the majority will be sent to for HPV in primary care. This is cervix with a CIN2 abnormality. You can see an ectropion on this one as well. It's a bit more white than the last image, and the margins are more distinct. So there's 3 options of treatment or not treatment in this case, or in many cases of CIN2, there's a conservative management option, an ablative option which destroys the abnormal cells, or an excisional which will remove them. And we'll go through the management of CIN2 now. Like I said, we're now looking at conservatively managing women of CIN2, and this is because many studies have been done. There's been great interest in the regression of CIN2 lesions. It's happening spontaneously without any treatment. The first study there was a systematic review and a meta-analysis. It identified 36 studies, which included 3,160 women. And this study reported regression rates of 50% in this cohort, 32% progression rate and only 32% persistence and only 18% progression rate. They also did a subgroup of this cohort in women that were under 30 within the study, and the regression rates were as high as 60%. The persistence was only 23% and it was 11% progression rates. The second study then is a cohort study in Denmark, and they're stating now that 50% of their CIN2 cases are being managed conservatively, and they're reporting in and around 47% regression rates, with similar rates for both younger and older women. And the BSCCP guidelines state that recommend that women who haven't completed their childbearing should be considered for conservative management. Now, we do have strict requirements for conservative management, strict guidelines that they need to be not have a treatment before, that they need to have multiple biopsies to confirm that it is only a CIN2. They need to be happy to come back to us every 6 months for 24 months to have a smear and a look and a biopsy possibly at that stage. That if they progress within the 24 months, they need to know that we'll then be recommending a LETS treatment. And if they remain persistent at the 24 months, then we'll be recommending a LETS treatment at that as well. Another option for treatment for a CIN2 is an ablative treatment, and this is cold coagulation. We use a SEM coagulator. We put in some local anaesthetic prior to treatment, and the heat source then is applied, and it boils the intracellular water and destroys both the abnormal and the normal cells of the transformation zone. I have a small video as well of this. This is from the IARC, and it's a really good resource for anyone interested in cervix. It's very quick, and I'll talk you through it. So they've inserted the local anaesthetic, they've applied the Lugol's iodine, and you can see now that the probe is on the cervix. They heat it to about 110 degrees for in and around 45 seconds, and they'll gently remove so as not to touch the vaginal walls and burn them. And that's what the cervix looks like immediately after. We will give the woman treatment advice then. We'll tell her that no biopsy has been taken, therefore she won't receive results in the post. But we will get a phone call from about 50% asking for her biopsy results. But just she needs to be aware. It's written as well, but we'll reassure her that, you know, there's no biopsies taken. She will have a PV discharge with a slight odor for around 2 to 4 weeks, and this is normal. We'll advise her to avoid sexual intercourse and use of tampons for 4 weeks, avoid bathing, swimming and jacuzzis for 2 weeks, but she can shower as normal. And we'll tell her to seek medical advice if she has any foul smelling yellow or green discharge and if she's feeling feverish. So this is a cervix of a high-grade abnormality. You can see that the acetic acid has been applied. There's some vascular patterns noted on this one as well. This is some coarse mosaic, and this is some punctation. And these are things that just indicate that it might be a high-grade abnormality. It's something for us to look out for on the cervix. You can see some mosaic pattern here and here. And you can see how white the acetowhitening is. This is a high-grade abnormality and a CAN3 on biopsy. So the management of CAN3 or for a glandular abnormality will be to remove the abnormal cells. It'll be an excisional. A large loop excision of the transformation zone, or LETS, is what we recommend. The local anaesthetic is applied during or prior to the treatment, and a wire loop electrode powered by an electrosurgical unit is used to resect the whole transformation zone along with the abnormal lesion, and a ball diathermy then is used to obtain hemostasis. So if anyone was squeamish at the last video, you might want to leave and make a cup of tea now and come back in about 2 minutes. So this is a LETS treatment being done. The images from, or the videos from the IARC, and I'll talk you through that as well. So the local anaesthetic has been applied and the Lugol's iodine has been applied as well. We use a special speculum with a smoke extractor. So you'll see that smoke does come, but it gets extracted out of the way straight away. So he'll make a dummy pass here with the loop to see where he's going to do the excision. And he uses like really slow and deliberate movements to guide across the transformation zone. And this just reduces the amount of bleeding. And he'll remove the piece of the cervix. And that'll get sent for to histology then to the lab. In this case, he does have to go back for a second pass, which happens. And he'll send both off to the lab. So he'll swap over now from the loop to the ball diathermy, and he will just, you'll see he'll start at the margins and work his way into the center. He'll be avoiding the cervical os to try and prevent cervical stenosis. And just the blood will pool at the bottom, so he'll do that last. There's a non-stick ball that you can get now as well, which is quite, it's quite good for. Quite a lot of gunk gets stuck around the ball diathermy, but you can remove it with a pad. So we use a Monsell solution as well to ensure hemostasis, and this has ferrous sulfate, sulfuric acid and nitric acid in it. It's very good for stopping the bleeding. and the speculum is removed partially just to check for any bleeders before it's fully removed. So we will discuss all of the risks of the LETs prior, obviously, to doing the LETs treatment. But treatment risks include infection, heavy bleeding, pain or cramping, cervical stenosis. There's a risk, but it's more often if you've had more than one LETs, or it's been a big LETs where they've removed more than 1 centimetre of the cervix, or you're postmenopausal. And there is a small risk as well of premature birth or late miscarriage. Again, the longer term risks are more likely if you've had more than one LETs or more than 1 centimetre of your cervix has been removed at the LETs. We will advise women that they may have a light bleeding or a brown discharge for 4 to 6 weeks, which is normal, on some bleeding for 4 to 6 weeks. We will tell them that we will get the results posted out to them when they are available. Some labs are having difficulty at the minute. So when your lab is able to get it out, when you know that it's coming through, you'll advise the woman. But generally, we'd hope to have it in around 4 weeks in Letterkenny. We advise her to avoid sexual intercourse and use of tampons for 4 weeks. Don't swim, bathe or use a jacuzzi for 2 weeks or until the bleeding stopped. If she's having bleeding up to 6 weeks, she can shower as normal as well. She should seek medical advice if she's having foul smelling yellow or green discharge, if she's feeling feverish, or if she's any heavy vaginal bleeding. So we advise colposcopy in pregnancy. We advise women to attend who have an abnormal cervical screening test. The main thing is to outrule, like the reason we do it is to outrule cancer. So we need to look at the cervix to make sure that it is a low-grade abnormality or it is just persistent high-grade HPV, and that we can wait until after pregnancy then to follow her up if we need to. We will do this in late first trimester or early second trimester. And this will reassure the woman as well. We'll reassure her that it's safe in pregnancy. We won't do biopsies in pregnancy. If we do think that there might be a cancer there, this will be with a small loop excision. So we will defer any biopsies until after. So if you do come across this when you go to take a cervical screening test, don't proceed, don't do it. Pick up the phone, ring colposcopy and tell them that you're saying, you'd like the woman seen as soon as possible, and send your follow-up written referral. So if a woman does have cancer and we stage it then with the FIGO staging, her treatment will depend on stage of the cancer, the size of the tumour, her desire to have children, her age and her pregnancy status, and her wishes. Like she may require a trachelectomy or hysterectomy or radiotherapy, chemo, or a loop excision, and a cone knife excision might be enough. All cases of invasive cancer are discussed locally at MDT to clarify and determine the management plan. We also hold monthly MDT meetings and we discuss the management of women who have a discordant cytological, colposcopic or histological findings. So basically, if she's referred in with a high grade, I look and I don't see anything, I take a biopsy and histology doesn't see anything, we'll discuss that woman then to see, right, we'll look at all the slides and we'll see what do we need to do now. Do we need to go ahead and treat, or should we re-see the woman, do everything again and decide? And any other clinical issues, we'll just discuss any woman that we're not sure of, or what's the best practice that we could, how we could manage this woman. So in attendance at our MDT meetings are all practicing colposcopists, representatives from cytopathology and histopathology, virologists as required, or admin support are there, and trainees and students are there. And any further management is based on MDT decisions. When we are discharging, I've noticed a lot more of a shared care between colposcopy and primary care, especially since the introduction of the HPV screening. We can ask women to have their screening tests in primary care either in 1 year or in 3 years or annually for up to 10 years. And this depends on the discharge plan, which is in accordance with the National Cervical Screening Guidelines. So in summary, please refer women to only one colposcopy clinic. Ensure that they have an abnormal cervical screening test or persistent high-risk HPV infection. Use the revision 11 pre-filled form and ensure that the full test report is there. If you are referring a woman with strong suspicion of cervical cancer, pick up the phone and let us know. Waiting times are dependent upon the result or her sample category, but they're usually between 2 and an 8-week pathway. That's our target. Colposcopy is a medical diagnostic procedure and it is done to decide is a treatment required. Normal colposcopic findings will include cervical ectropion, Nabothian cysts and cervical polyps, and these do not require a colposcopy referral for reassurance. Abnormal colposcopic findings include acetowhite staining with histological reports of SIN1, SIN2, SIN3, CGIN, which is your glandular or cervical cancer. The colposcopic management or treatment of patients is dependent upon the grade of the abnormality, and ultimately the patient's wishes comes into it. We provide written post-treatment advice to all of our patients. We discuss some patients at our monthly CPC MDT meetings. And finally, I definitely have noticed a more shared care approach between colposcopy and primary care since the introduction of HPV screening. Thank you. And that's the references as well with the IARC colposcopy digital atlas.